This is Connor Meadows going over the bradycardic algorithm for paramedic care. If you have a patient that you have taken care of their airway, breathing, and circulation and have hooked them up to the monitor and realize that they are in a bradycardic rhythm, the treatment will go as follows. You will assess the appropriateness of the bradycardic rhythm treatment. Their heart rate will be less than 50 per minute. That will mean they are having a bradycardic rhythm. You will make sure that you maintain their airway and assist breathing if necessary. You will give them oxygen if they are hypoxic. You will have already hooked them up to the monitor, and you will be monitoring their blood pressure and pulse oximetry, and you will have given them IV access. Once the 12 lead is available, do not delay the treatment therapy. If they are having persistent bradycardia, you will treat them with atropine, initially a dose of 0.5 milligrams. You will repeat that every 3 to 5 minutes to a maximum of 3 milligrams. If atropine is ineffective, you will consider transcutaneous pacing. Also, other medications that can be given besides atropine are dopamine and epinephrine. Dopamine is usually infused at a rate of 5 mics per kilogram per minute, and you will titrate that to the patient's response and taper it slowly. Epinephrine IV infusion for a bradycardic algorithm is 2 to 10 micrograms per minute infusion rate. If the patient is initially in a bradycardic algorithm, but it is not persistent bradycardia and they are stable, you will monitor, observe, and transport the patient. We will only be giving patients medication and transcutaneous pacing if the patient is unstable and symptomatic. So again, to go over one last time, for the bradycardic algorithm, you do not delay treatment, but you will always be thinking in the back of your mind about the H's and T's. So once you have maintained the airway and hooked the patient up to the cardiac monitor and realize what their blood pressure and oxygen saturation is, you have established an IV, and if the patient is stable, you will transport the patient. If the patient is unstable, symptomatic, you will administer atropine at 0.5 milligrams IV bolus, and you will treat every 3 to 5 minutes to a total dose of 3 milligrams. If atropine does not immediately relieve the bradycardia, you will continue evaluating the patient to determine the underlying cause and consider transcutaneous pacing. Again, other medications you can also treat the patient with if they are symptomatic and unstable is a dopamine infusion of 2 to 10 mics per kilogram per minute, which for us, we will start with a 5 mics per kilogram per minute and then titrate from there. And you can also consider epinephrine at an infusion rate of 2 to 10 mics per kilogram per minute. This has been the bradycardia algorithm for paramedic care.